Upfront, I like to thank the organizers and the team for giving me this opportunity. We will be discussing briefly the newer paradigms and treatment in resected EGFR mutated lung cancer. Can you shift the slides, please? So, lung cancer, early lung, in our common day-to-day practice, we usually see that bulk of our patients are made of the advanced lung cancer, which is 3B to 4 for the classification purposes. Around 15 to 17% of these patients are early lung cancer. Can you change the screen, please? The primary modality of treatment for this population remains surgery, and as was discussed earlier, but there'll be a subgroup of patients for which SBRT would be used. Specifically for stage 2, stage 3A lung cancers, we give adjuvant chemotherapy to most, and these are platinum-based doublets. For a subgroup of 1B also, we give adjuvant chemotherapy. We know from our previous experience and the studies available that the benefit of this adjuvant chemotherapy is around 11% of mortality benefit. Despite of the best treatment available, can you please change the slide? But despite of the best treatment or the care available, we see a large proportion of these patients recur. And this rate of recurrence is higher as we move ahead up in the ladder of these stages. So stage 3A, around 76% of the patients would have a recurrence by 5 years, and this would be around 45% for stage 1B. Would you be able to change the slide, please? So, and the other part to note is that these changes or these recurrences predominantly occur at a distal site, of which CNS recurrence remains as the most dominant site of recurrence, followed by lung, bone, and liver. Can you change the slide, please? So a significant number of modalities have been tried to ensure that these recurrences or the survival in this specific subgroup occurs. In a subgroup of EGFR mutated lung cancer, a common thought that can come in most of the minds would be adjuvant EGFR inhibitors, and that has been studied earlier too. So there were certain studies in which EGFR mutation was selected, others were not. So we'll briefly touch on the two common or the two important trials that were done. One was the Adjuvant trial, the other was the Adjuvant trial with erlotinib and gefitinib respectively. And both of them showed a significant DFS benefit with the hazards ratio of around 23.27 for the advanced trial and around 0.56 for the adjuvant trial. Would you be able to change the slides, please? But we see that here the duration of the adjuvant therapy was almost 2 years. And when we see the Kaplan-Meier graph after 2-year duration, the gap between the two graphs starts slimming. And as is expected, there was no survival benefit with these interventions, and hence we have moved beyond it. Could you change the slides, please? So when we see that we have already tried something prior and have failed, then why try another drug of the same class? So osimertinib, we know that provided with two specific advantages, and that was the reason why it was studied in the ADAURA trial. One, that in the advanced NSCLC, we know that osimertinib actually improved OS when compared with the first generation TKIs. And second, as we remember from the problem ahead, that most of the distant recurrences that we are having in the early lung cancer were CNS, and we know that osimertinib is significantly effective in preventing CNS mets. Would you be able to change the slides, please? Hello? And with this thought, change the slide, please. So with the thought, we come with the ADAURA trial. So change the slides, please. So in the ADAURA trial is a phase 3 double-blind trial where we compare, we include patients with stage 1B to 3A non-small cell lung cancers, which are EGFR mutated, resected, and are margin negative. The important part here is that we are including patients who had either received or not received chemotherapy. So there are both subpopulations here. And second thing to note is that here we are comparing osimertinib with a placebo, whereas in the Adjuvant trial or the Adjuvant trial, the comparison was with chemotherapy arm. The primary outcome is DFS, and the secondary outcome was DFS in the overall population. So the primary was DFS in stage 2, stage 3 only. Secondary was DFS in the overall population, as well as overall survival amongst the others. The plan was to give osimertinib for 3 years, but in the interim trial, because of the evidence of efficacy, the trial was stopped and the trial was unblinded. Could you change the slides, please? So when we look at the baseline data or the demographics, we see that they are predominantly female, as would be expected in an EGFR mutated trial. They're in their early 60s, all fit patients, and around 60% of them have received adjuvant therapy. And when we see their comparisons in stage 1B, 2, and 3A, we see they're almost equally divided in these 3 stages. Would you move ahead? Change slides, please. So as was expected, the DFS outcomes of this trial were excellent. So we see that there are 2 graphs which are completely separated from each other, and with a hazards ratio of 0.17. So there's almost 83% reduction in the risk of recurrence or death due to tumors. Would you change the slide, please? And similarly, when we see at the secondary endpoint, so when we include the stage 1B tumors also, then too we get a hazards ratio of around it was around 0.20. So there is an 80% reduction in the risk of distant recurrences or death due to tumor. Would you change the slides, please? So then we tended to find was there a subgroup which was definitively benefited or which was not benefited? So we say irrespective of the race, stage, EGFR mutation status, or the adjuvant chemotherapy status, all subgroups benefited in terms of a benefit in DFS. Would you change the slides, please? So in terms of the stage, we see that the maximum benefit is in the subgroup where there is a maximum chance of recurrence. So 3A gets the maximum benefit out of the intervention. Stage 1B gets the least benefit, but still, even in stage 1B, the hazards ratio is around 0.39. So there's significant benefit. We will change the slide, please. Thank you. So in terms of chemotherapy, so there are 2 factors that we are looking at: stage and if they have received chemotherapy or not. So we looked at if irrespective of the stage, patient benefit, but the benefit is greater if they have received, if the stage is higher. Similarly, irrespective of the fact that patients have received chemo or not received chemo, there is a benefit in DFS. And the hazards ratio ranges from 0.16 to 0.23. So there's significant benefit. Would you change the slides, please? So we'll delve into this chemotherapy based data a little more later on. But the first and most important is the overall survival data. So the data was not mature and it is something that is awaited. Will you change the slide, please? When we see it,
sorry to interrupt, you need to conclude in next 1 minute, sir.
Sure.
Last one.
Definitely. So where the recurrences were occurring was predominantly at the distal site, and osimertinib was decreasing these distal recurrences. Change the slides, please. And the second benefit that osimertinib was giving in the terms of CNS recurrences. So the CNS recurrences was significantly lower. Would you move on to the second last slide, please? Second last slide. This we have discussed. Thank you. So in terms of second last. So in terms of ADURA or summarizing, we know that it is a trial of adjuvant osimertinib stage 1B, 2, 3A, where there is significant improvement with DFS, regardless of the stage or adjuvant chemotherapy status. And there is meaningful improvement because the CNS metastasis risk is also reducing. Last slide, please. The second last. So my take on it is we should discuss this option with all patients, explain them the risk of morbidity at relapse versus the fact that we do not have an overall survival data and the cost that it incurs, and then let the patient decide. till such time that an overall survival data is available. And let us hope that this intervention would deliver us a good survival benefit. Thank you.
Thank you, Dr. Akash, for a nice discussion on newer paradigms in resected EGFR mutated early lung cancer. So without wasting time, we'll move on to a panel discussion. So the moderator for panel discussion is Dr. Prashant Penumudu, who is a dear friend of mine and an associate professor at Department of Surgical Oncology, JIPMER, Pondicherry. Also, I would like to call the panelist, Dr. Chandni Hotwani, who is a senior consultant radiation oncologist at Alexis Multi-Speciality Hospital, Nagpur. Dr. Piyush Shukla is a senior consultant radiation oncologist at NHMMI, Raipur. Dr. Parag Ingle, senior surgical oncologist at HCG NCHRI Cancer Center, Nagpur. Dr. Shubham Garg, we already heard his lecture on segmentectomy versus wedge resection. So, senior consultant, Fortis Hospital, Delhi. Dr. Sarvana Rajamanikam, again, Sangam Cancer Center Director and Senior Consultant Surgical Oncologist. Dr. Jaswant Jain, he's a consultant surgical oncologist at Raipur. And Dr. Gauri Hattas, who is again an alumni of TMH and consultant pathologist at Kingsway Hospital, Nagpur. I would also like to invite Dr. Nikhil Pandey. Since we are in this panel, you know, we are lacking a medical oncologist. So Dr. Nikhil Pandey, who is a senior consultant medical oncologist at HCG Cancer Hospital, Nagpur. So over to you, Dr. Prashant, for management of early stage lung cancer panel discussion.
Hi, thank you, Amol. Am I audible?
Yes.
Yeah, sure. Thank you, Dr. Amol, Dr. Nikhil, for giving me this. Without wasting much time, I think I already have my expert panelists. All of them are eminent panelists in the management of lung cancer. And over the next 20 minutes, we will be taking you across the management early lung cancer. Some facts and figures, unpublished data, but in publication. For burden in India constitutes about 5.9% lung cancer and 8.1% related death. Surgically resectable or eligible is about 1.5 to 5.3%. And unfortunately, though 31.17% in this data comes from one of the tertiary cancer centers across in the country, there is severe underutilization of undergo a curative treatment. So now coming the first thing, like what's the panelist experience on, you know, what percentage of patients are early lung cancers in practice? I would start with Dr. Parag.
Hello. So majority of the patients which we are seeing for lung cancer are metastatic or locally advanced who are not amenable for surgical resection, and very few patients turn up for surgical resection. That is the picture all over India, I think. And regarding COVID, after the COVID second wave is subsiding, especially in Nagpur, and definitely I have seen 2 cases of localized clinico-radiologically localized lung cancer after this second wave is subsiding. So COVID
okay, yeah, Parag, I think it looks more or less that about, yeah, Shubham, Dr. Sarvana, what's your experience on early lung cancers?
So the acceptability of getting a CT scan has definitely increased. HRCT is the new lexicon which has people have added in their own vocabulary. So people are more in tune to get a CT scan done now. Yes, definitely early lung cancers have increased. We are now getting more and more smaller lesions. But having said that, the number of inoperable have also increased because the total pickup of cancer has increased because of more CT scans being done.
Dr. Chandni, how frequently do you see early lung cancers with that count to you for SBRT? And do you think that COVID times has increased a little bit?
Dr.
Chandni, can you hear me? Yeah, okay, fine. We'll move on to the next slide. Dr. Shukla is around. Yeah, so this is the 8th TNM classification that you've seen. There are some subtle changes, and I will be covering early lung cancer. I will not be covering operable lung cancer. The one marked in blue is the operable lung cancer wherein we could offer surgery. But early lung cancer is something that is marked in green. So I am keen to cover these group of lung cancers as of today. So here is a 48-year-old gentleman, incidentally diagnosed, non-smoker, no comorbidities, ECOG1. And this is a lesion in the right upper lobe, measuring about 2.8 centimeters, and biopsy was a mucinous adenocarcinoma. So my first question to Dr. Gowri, before I move on to the next.
Hello.
Yes, Dr. Gowri. So the mucinous adenocarcinoma is something like, how frequently do you see in a lung cancer, and how challenging is it to differentiate from others? Yeah, Dr. Gowri, can you hear me? Dr. Gowri, can you unmute yourself?
Prashant, I think we'll move forward. Shall I take this question? So
actually, yes, please. Yeah, Doctor. No, she's trying to unmute. Yeah, yes, Dr. Gowri. I request all the panelists to unmute themselves so that we would save some time.
Hello. Sir, can you please repeat your question?
Yeah. So mucinous adenocarcinomas of the lung, how frequently do you see them in your practice, and what are the challenges that you face diagnosing these kind of cancers?
Yeah. So especially in male who are non-smokers and in female, we generally see adenocarcinoma, and in that we many of them we see mucinous adenocarcinoma diagnosis. But when these cancers are poorly differentiated, like when it is not possible to differentiate between the squamous and adeno, for those patients we need IHC or help of molecular pathology.
Okay, yeah. So yes, Sarvana, you have something to add, Sarvana?
With this COVID, we are getting more and more patients who are female and male, non-smoking candidates coming up with lesions in the lung, and most of these lesions, this is actually the group, which have mucinous tumors, non-smokers, females, classic situation.
Yeah. So next question is to Dr. Jaswant. Hi, Jaswant. Like, how would you stage further? This patient comes to you with an HRCT right now with a lesion, and a biopsy done shows mucinous adenocarcinoma, peripherally located less than 3 centimeters.
If the facilities are available, I would like to get PET scan done if the facility is easily available.
Okay. Yeah. Any other? Yeah, PET scan. I'm sure that definitely is a mandatory investigation. Shubham, would you like to tell us about something more about the PET in terms of advantages and limitations that you see across in this patient particularly?
Shubham, unmute yourself.
Shubham, please.
Sorry, my bad. So see, the purpose of getting PET scan in such a size tumor is to rule out one would be a distant metastasis and second would be nodal disease. So this is more problematic with the nodal disease because the sensitivity of the CT scan, the PET CT scan goes down with the size of the nodes. So if it's anything less than probably 1.5 or 1 centimeter, then you are not so sure with the nodal staging, and then you would want to get an invasive staging also. So a PET CT is a must, but then if there is any doubts in the nodes, I would want to go for a EBUS.
Okay, so we'll have two scenarios right now. And I would request Dr. Sarvana. PET CT shows only uptake in the primary with an SUV of 1.7 and no uptake in the no uptake elsewhere. So what would you do next, Sarvana?
If there are no lungs, if the CT scan image of the PET CT scan shows no lymph nodes around the around the mainstem in N2 region, I would straight away prefer to stop staging investigations and go for surgery. If there is any lymph node that is seen on the ipsilateral side or the opposite side, any side, then I would be inclined, whether it is PET avid or not avid, especially in the mucinous scenario, because mucinous are known to notoriously have low uptake for PET scans. So if there's any visible lymph node on the CT aspect of the PET, on either side, on N2 or N3 side, I would consider invasive staging for this group. I also want to mention that in adenocarcinomas, whatever the size, I always have seen a lot of patients with even 1 or 2 centimeter size tumors having brain mets. So I think we should not forget the MRI brain in this situation, especially if it is adeno.
So yeah, very good points raised out. You see, adenocarcinomas, low primary SUV. If there are anatomically nodes present, please do consider. And I completely agree. Dr. Parag, what's your take on brain metastasis in adenocarcinomas especially? And Dr. Sarvana recommends in a T1C N0 M0 in all cases of adenocarcinoma. Do you agree?
The brain imaging, I agree, but sometimes even instead of an MRI, the CT component of the PET CT can show you if there are any brain lesions. So if at all there are any logistical reasons, the CT brain, contrast CT brain would suffice, especially for peripheral small tumors.
Okay. So, Nikhil, Dr. Nikhil, do you routinely recommend a brain imaging?
Sir, can I get it again?
Yeah, good. I mean, do you routinely recommend, when do you routinely recommend a brain imaging in non-small cell lung cancer?
I don't, sir. Only if symptomatic. I know the guidelines say you should, but I don't routinely recommend, not as a practice, sir.
Yeah, but a very valid point, especially in adenocarcinomas, the incidence is higher, but for routine imaging, it's still debatable whether you should routinely get a imaging or not, but I completely agree with Sarvana's point. Okay, so now let's say that there is a PET positive node in the right paratracheal region, that is level 4. So how would you wish to further proceed? Dr. Jaswant, would you like to take this? Dr. Shubham, if Jaswant is not, would you like to take this, Dr. Shubham? PET positive right paratracheal node, unmute yourself, Shubham.
Node less than 2 centimeter, I would want to paratracheal, I would want to give neoadjuvant chemotherapy and then proceed for a response assessment.
No, we have not evaluated further. It's only a PET uptake. So would you like to do or just PET uptake?
EBUS for sampling of that node along with the subcarinal and the opposite side nodes if there are any.
Okay, so to the audience, in the interest of time, it is mandatory to do an non-invasive followed by, so when would you do an invasive? Like, is invasive mediastinoscopy, is there in your armamentarium, Sarvana, Shubham, at any point of time, or have you just taken off mediastinoscopy off your armamentarium?
No. I still perform mediastinoscopy in one scenario where you have a node on the right side, EBUS was negative, on the left side. If an N3 station node that is visible on CT scan and showing some uptake is negative on EBUS, that is the only situation where I would go in and do an invasive mediastinal staging to confirm that we are not operating on an N3 disease. Otherwise, if it is N0 on EBUS on the left side, like you said, I would proceed with surgery because we are going to do a lymphadenectomy anyway.
Okay, great. So mediastinoscopy still has a role to play, though, and EBUS and US combined is probably the best modality. So these are some of the data with PET. I will just quickly rush through. All these have been discussed. The only problem is with false positive, especially in India where benign infectious disease has limitations of the PET pathological N2 disease. PET CT is not adequate because you still have, even though negative, you can still have a positive nodes on EBUS or EUS if there are anatomically nodes present. So PET can be omitted in indications are anything more than 3 centimeters centrally located irrespective or a suspected N2 disease. And this is an interesting radiological classification which I have found, wherein only in the category D, mediastinoscopy or invasive mediastinoscopy is not indicated. A, not required. B and C, you should do it for taking definitive management. Now coming to treatment options. So we take PET negative, mediastinoscopy staging not done, CT1C, N0, M0. Now here I would put forward my question to radiation oncologist first. I know there is no debate. So if this patient lands up in your clinic, Dr. Chandni, is Dr. Shukla there with us? Because I couldn't see him on the screen. If he's not there, Dr. Chandni, so if this patient sits in your OPD, what would be your
Chandni, you have to unmute.
Chandni, Dr.
Unmute.
Chandni.
Chandni, please.
Unmute. The lower end. Oh.
Yes, Chandni, please go ahead. So SBRT, patient is sitting in front of you, SBRT versus surgery.
Chandni, we can't hear you, Chandni.
Okay. Yeah. So I think Chandni, Parag, would you like to take this question until we get back to Chandni?
Okay, so peripheral 3 centimeter lesion, I would like to assess the patient, his fitness for surgery with lung function test and a 2D echocardiography. And my first preference definitely would be
I'm sorry, he is a fit patient. I forgot to, I mentioned briefly that he's an ECOG1 with a good fit patient.
Surgery
48 years, comorbidities, and then fit patient.
So definitely I would counsel the patient for surgery instead of SBRT. Definitely, since the patient is fit for surgery, the first option of treatment would be surgery, and that is what I would counsel.
Okay, any of the surgeons would send this patient for SBRT? Sarvana just spoke in favor of SBRT a few seconds ago.
Never.
He himself
So,
won't send it
no.
back.
Never. No, not in this case.
Okay.
Anatomically, this
Not
case.
in this patient, yes.
If you look at anatomically, this
Chandni, if you are ready. Chandni, if you are ready, can we take your opinion?
Waiting for a radiation oncologist to pitch in.
She should unmute. Chandni, unmute, please.
I thought she would grab the opportunity. Anyway.
Yeah.
This is a bias.
We'll come back, Chandni. Sometime as we will.
Zoom is also against radiation oncologists. So,
okay. No
just to
problem.
fill in,
I think there are some tech.
Yeah, so just to fill in, I would say
yes,
that
yes, sir, please.
This patient is a 2.8 centimeter lesion. It's just bordering around 3. I'm sure it will be 3 when you get the tumor out, and it's quite close to the fissure. And I feel that in this case, SBRT should be offered for patients which are a little away from the fissure and which are outside the safe zone, in the safe zone, that is outside the central bronchi and not very close to the ribs. So this is the area where you look for giving SBRT for patients. Anatomically, this patient does not fit because they are very close to the the fissures as well. So yes, if the patient was medically inoperable, when you have no other choice, maybe SBRT would be the way to go, but not an operable fit patient.
So actually, Chandni is writing in the chat box that she would give an option of SBRT versus surgery. My first comment or my first request is just assess fitness for surgery before you give, or get at least PFT done before you give that option, because you have to see whether the patient is amenable to a surgical treatment or not.
Now, Shubham, I wanted to ask you, Shubham, if the patient was medically inoperable. Now, this case is, Prashant, this case is to you as well. This case is 2.8 centimeter, no lymph node in the mediastinum. Would you offer a segmentectomy for this patient if the patient was medically inoperable? Medically, you understand?
Yes. So my issue would be with the margin, just the margin, because the CT ratio has to be 1 or more. So giving a margin of 2.8 centimeter either side would entail me taking a tissue as good as 9 centimeter. But if you were to do a segmentectomy is feasible for this patient with a lesser margin, and I would not hesitate to give in this patient. It's a peripheral lesion. They would get a good thing to segmentectomy actually.
Prashant?
Yeah, Sarvana, I have gone through the images, which only I have access because it's my patient. I wouldn't, if he's medically inoperable, I would send the patient for SBRT.
Okay.
So whatever Shubham has just raised, it's not feasible in this patient. So I completely agree with Shubham. I was lucky to have the whole sequence. So I wouldn't treat this patient with a segmentectomy in this patient. And important points raised. Yeah, lobectomy and sublobar resections, I think, has been extensively covered by Shubham. So I will not touch upon. And Shubham, can I take your word that lobectomy is the standard of care as of now?
It is.
Or is there any patient that you would recommend a sublobar resection?
So with longer survival patients who are coming with previously lobectomy done, probably you can offer those to those patients only. Should offer them.
Okay, yeah, great. Coming to the next. So when would you offer? That you've already answered. Now coming to the next question, mediastinal sampling versus lymphadenectomy, because I think this is one thing which Sarvana during the talk debated that, lymphadenectomy can be done effectively in surgical setting, but not in an SBRT setting. Yes, Dr. Parag, would you like to take this question?
Yeah, the question I would like to mediastinal sampling versus lymphadenectomy. So an ECOSOP trial has shown that there is no definite survival advantage of completing a lymphadenectomy over just sampling the nodes if the nodes turn out to be negative. Especially if the nodes were negative on EBUS and if at all you have facilities of frozen section, and if on frozen section the samples are negative, then there is no advantage of completing the lymphadenectomy. So mediastinal sampling, a systematic mediastinal sampling would also suffice. And it is important that at least 3 N2 stations are adequately sampled during the surgery.
So what's your take, Sarvana, on Parag's comment? He says that sampling is adequate. I am for a systematic lymphadenectomy. Let me confess first.
Yeah. Actually, I was fortunate enough to work with the person who was the primary author of that study, and she was, the centers which were doing sampling were actually doing a lymphadenectomy. So it was very difficult to differentiate in that study, if you will go into the details, to differentiate between what the groups were doing in sampling versus what the groups they were doing in lymphadenectomy. If you look at that study, 6 stations were supposed to be sampled, and any lung surgeon will know you just cannot sample without doing a lymphadenectomy most of the stations in the lung. In the lung. So imagine you're doing inferior pulmonary vein lymph node sampling. That's going to be a lymphadenectomy. Subcanal, you can't just do pick nodes. Most of them would do complete removal of that node. So they had a difficulty in actually differentiating the concept of sampling versus lymphadenectomy. So that being said, some form of lymph node evaluation is a must in surgery, and at least 6 nodes should be removed from, like rightly Parag said, 3 stations minimum.
So yeah, very rightly said, sampling group.
So we have last 3 minutes to conclude your presentation.
Yeah. Yes. Sure. So I will not go into the surgical open versus minimal invasive. Dr. Sarvana has covered it briefly. Shubham, one last word on which groups that you should mandatorily sample for left-sided disease. Group of to be mandatorily done for a.
I can't get the question, Prashant. There's a lot of chatter in the background.
For a left-sided
I'm sorry.
cancer,
So tell me the stations for a left-sided and right-sided. Which are the groups of lymph nodes that you would?
Okay.
Yeah.
So the N1 packet, which is 10 to 14, would come out with any type of cancer that would come out. We would talk about the N2 stations basically. So 2R, 2, 4R, and 7 would be the one that would be definitely be taken out along with the mandatory N1 stations. On the left side, that would be 2L, 4L, 5, and 6, which should be taken out, and 7 along with the primary disease.
Fantastic, Shubham. Thank you. So this is the histopathology. As you can see, it is a 2.8 centimeter involving the visceral pleura. I wish Dr. Gowri to come in now. 0 out of 20 nodes and spread through air spaces is absent and margins are free. For the interest of the audience, Dr. Gowri, could you tell us what is the STAS, which has been recently figured in majority of the guidelines, and what is its clinical importance?
Sir, STAS is the spread of a tumor beyond the edge of the tumor into the adjacent air spaces. And in adenocarcinoma, it is not very common to see STAS in a resected specimen, and it has been seen that STAS is associated with local recurrence.
Yeah, so that's a very important point made, Dr. Gowri. STAS is important, is associated with local recurrence. And the only difference would have been a T1C if we were following 7th, but due to involvement of visceral pleural involvement, this has become a PT2N0. Now, what next, Dr. Pandey? A role of adjuvant chemotherapy in this patient, 2.8 centimeters, visceral pleural involvement, node negative disease.
Sir, adjuvant chemotherapy is anyways warranted for any T2N0 disease, and we would consider adjuvant. Now the question is, what is the adjuvant that we would want to give? Cis vinorelbine versus PEM-cis or something?
Adjuvant is needed?
So T2N0, 2.8 centimeter.
Yeah, so Nikhil, why I have put this question specifically because just a mark of, I'll just take one more minute. I request the organizers because all the trials actually have looked at tumors more than 4 centimeters.
Yes.
So the visceral pleural involvement, new indication, which is upstages the tumor to T2. So would you really warrant to give based on, because is there evidence only based on this feature that you consider adjuvant chemotherapy?
So yes, so that T2 making it is what would make me want, because so this is the end of it. I mean, after this, if it recurs, visceral pleura is already involved, and you have a study based on which you have visceral pleura involvement warranting adjuvant therapy.
Okay.
So
I mean, yes,
so we would
this
obviously
for,
err on the
debate
side of caution and consider adjuvant.
Okay, yeah. So yes, we had a doubt. So routine molecular testing has been excellently covered, and I think now you should do any role of adjuvant TKI, Dr. Nikhil.
So now even
Would you consider
at this point of time, even
patient?
adjuvant chemotherapy is a little doubtful. So no adjuvant TKI at this point of time.
Okay, so I thought you would say that you would definitely want to put this patient on osimertinib if the patient turns out to be EGFR.
So yes, but if you look at the data, that adjuvant osimertinib, the trial, it's a little flawed trial. I'm not anybody big to comment on that, but the adjuvant osimertinib, the benefit was compared with something, Edura. Yeah, it was, the benefit was huge and everything was huge, but then you really ought to consider that whether, how many of them do you test for it? Here, it's only because of visceral pleura that we are considering this one. After that, adjuvant TKI, I think it would be a little overkill.
Okay, yeah. Points very well valid and well taken. So we'll leave it. Dr. Jaswant, your last comment, local recurrence after curative treatment in early stage.
Hi.
Yeah,
Hello?
hi Jaswant. So how, yeah, what's your local recurrence after last slide? Comments on local recurrence after treatment.
We will have to work it up again to see the extent of the recurrence. But resection of obviously it will be a difficult scenario. It's not audible. Hello?
Yeah,
Hello?
you're audible. You're audible, Jaswant.
Yeah, you are audible, Jaswant.
Okay. We will have to work it up again with the PET scan and CT scan and see. I don't think. First, we have to assess if it is resectable or not.
Sure. Okay, yeah.
Hello?
Yeah, Dr. Shubham, post-treatment surveillance, word on post-treatment surveillance.
So 3-monthly chest X-ray with a lot of people are getting a yearly PET CT scan. I am not in favor of those, but yearly a CT scan of the chest, once a year CT scan of the chest is what I usually do. That is all. 3-monthly chest X-ray with the ELAC.
Yeah, and final word on survival outcomes, Dr. Sarvana, would you like to take this question? And then we would end, will end the session.
Everyone should know that stage 1 lung cancer, even up to stage 2 lung cancer, surgery forms a pillar of treatment in an operable patient. And SBRT finds role definitely in patients who are medically inoperable. Survival in stage 1 is as high as 95% if surgery is done adequately and properly, as mentioned by the panelists in this panel. So it's very important that we pursue aggressive treatment, because this in early stages, lung cancer survival is almost even better than breast cancer or as equal to thyroid cancer. So it's very important to understand that a good surgery, good lymphadenectomy, and if needed, adjuvant treatment will give a cure even for this dreaded disease. I'll suffice with that.
Thank you. Thank you, Dr. Sarvana. Shubham, one concluding statement.
So do not close your eyes to surgery. I'm sorry, I'm a surgeon, so I'll have to conclude with that. Please do consider surgery whenever you offer a patient SBRT, especially for early lung cancer. Get it in through your surgeon before you tell them that you are not operating.
Dr. Parag, conclusive statement, please.
Yes, surgery is definitely the curative option for early stage lung cancer, and a thoracic surgeon assessment is very much needed.
Dr. Chandini, if you're, yeah,
yes,
okay. Dr. Nikhil.
So, sir, it is a domain wherein we come in much late. But yes, surgery, or if you are considering for SBRT, then exactly like Shubham sir said, that it should be run through the surgeon first and then let him say it is inoperable and then consider for SBRT.
So,
yeah, thank you. I would like to, with this, I would like to
Prashant Chandni's comment is await the result of randomized trials with medically operable being given option of SBRT.
Okay. When is it coming?
Excellent,
When is it coming?
Excellent, Dr. Chandini. Yes. So I would like to conclude that each and every patient should go through a multidisciplinary tumor board. Patient should be explained about the pros and cons of surgery as well as SBRT in lung cancer. Yes, I am a surgeon. I am biased towards surgery, but I would still leave the option open. And Chandni, I agree with you. We'll all eagerly wait for the trial results to come up, and then hopefully we may try and refer patients, those who are not keen on surgery, for SBRT in future. But still, surgery as of today remains the gold standard. Lobectomy with systematic lymph node dissection followed by adjuvant chemotherapy as and when required, and molecular testing and SOS TKIs should be considered in these group of patients. I thank organizers for this wonderful chance, and I thank my eminent panelists for being active all through. Thank you once again.
Thank you very much, Prashant, for a superb discussion on management of early stage lung cancer. Since we already exceeded our time,